Let me share the screen recording. Good afternoon, everyone. Today I will be speaking about exercise, functional, and lifestyle medicine as an interventional clinical physiology. I am Dr. Hanjabam Barun Sharma, medical and clinical physiologist as well as sports and exercise medicine specialist, and currently I am the president of Indian Society of Sports and Exercise Medicine. So, first of all, the most important interventional aspect of clinical exercise physiology is sports and exercise medicine. And sports and exercise medicine has two components. There is sports medicine component as well as exercise medicine component. And sports medicine component, the basis is formed by performance-related sports and exercise physiology. And the main purpose of the sports medicine is enhancements, optimizations of the performance with minimizations, injury, and illness. Whereas exercise medicine component is formed by clinical exercise physiology, where exercise and physical activity is used as a for the promotion of the health and fitness as well as for therapeutic use of the exercise for prevention and treatment and rehabilitation of various medical illness and injuries. So this is basically sports and exercise medicine speciality. Apart from sports and exercise medicine speciality, clinical and interventional exercise physiology and clinical physiology form the basis for functional medicine and lifestyle medicine also. Functional medicine, in the functional medicine, the most important focus is on the root cause of the symptoms, or why there is the symptoms, what is the reason for the symptoms. If you identify the root cause by using various physiological intervention like nutrition, like exercise, sleep, gut health, stress resilience, spirituality, supplementation, mental well-being, mental exercise, we want to counter that particular root cause which is causing the symptoms, and hence going into the long-term cure of that particular illness or injuries. This is basically the principle of the functional medicine. And here, the functional medicine, we can see that the clinical exercise physiology form the basis. Same here for clinical lifestyle medicine, where different lifestyle-based intervention, which are basically the clinical physiological intervention, are done to treat the various conditions of the lifestyle or various diseases which are associated with the abnormality of the lifestyle, which are associated with the current practicing lifestyle, which may be nutrition, exercise, stress, sleep, environmental influences, sleep, and community, interpersonal relationship. All this matters in case of the lifestyle medicine as well as the functional medicine. We all know that these are basically the physiological aspect, and hence the physiological intervention. And and therefore, the core basis of the treatment involves the physiological intervention and physiological principle, like, for example, diet, nutrition, sleep, meditation, and this form the core. Whereas after these, you can go further into the pharmacotherapy and surgery as per the requirement. But the basis, the core is formed by different physiological intervention. So the doctor of the future will give no medicine, but will interest his patient in the care of the human frame, diet, and in the cause and prevention of the disease. It was said by Thomas Edison. That's why sports and exercise medicine, especially the exercise component, the functional medicine and lifestyle medicine, they form the future of the clinical and interventional exercise physiology, or clinical and interventional physiology. Let's more focus on the movement part, exercise medicine part, because in this talk I will be covering more toward the exercise medicine part. The movement is medicine because the movement is is intricately related with our evolution itself. The human was evolved as a endurance runner. We evolved in the plain of the Africa as a persistent hunter, and the evolution of the human brain is said to be produced adaptable in a complex movement, and hence movement and physical activity is so much important for our health, because our evolution is basically because of it. We were a persistent runner as well as persistent hunter, as well as endurance. We walk for a long duration of time during that in the time of our evolution. And we have basically made a documentary on exercise and brain health, and this is available in YouTube. When I was working as an exercise in senior resident in the Department of Physiology at AIIMS New Delhi. It is available freely. So next, going into the concept of the exercise medicine, it was jointly launched by American College of Sports Medicine and American Medical Association in 2007, internationally in 2010. Exercise medicine is basically a global initiative to make physical activity in medical care, that is for health promotion, prevention, and treatment of various medical conditions. And it is mostly important in case of the India, because the physically active, among the physically inactive adult, India ranked fifth among Southeast Asian countries, and it is above 12 countries worldwide. And the diabetes and hypertension prevalence is so high in India that India has currently most of the time refers also as a diabetic capital of the world. So one has to know all these things. And hence, exercise medicine initiative was launched by our society, that is Indian Society of Sports and Exercise Medicine, as well as in collaboration with the Sportsneck Institute and the Public Health Foundation of India. And we are in the preparatory phase where we very soon, in the coming future, we will be launching this exercise is medicine, the national center in India. Why exercise is medicine? There are lots of documentation for the different benefits of exercise and for the medically effectiveness of exercise. Like for example, here you can see that for coronary artery disease, exercise is as effective in reducing the mortality outcome as other drugs, other like statin, beta blockers, ACE inhibitors, and platelet, and all these things. For stroke, exercise is hugely beneficial over a reduction of the mortality as compared to other drug therapy like anticoagulant and platelet. Similarly, for heart disease, exercise is also effective. For pre-diabetic, exercise is also effective. So similarly, the hazard ratio is reduced with various exercise intervention. It may be muscle strengthening, or it may be aerobic combination of the both. And the reduction is obvious from this graph, where especially for this one, where chronic lower respiratory disease reduction is there. Also there is reduction in all cause mortality. And exercise benefit as compared to the drug and surgery, we see that in case of the cardiac disease, there is 40% reduction, risk reduction is there. For stable coronary artery disease, there is 88% survival at 12 years by exercise intervention. For type 2 diabetes, 58% reduction in incidence. For breast cancer, say 40% risk reduction. For major depression, exercise is as effective as sertraline. That is 60.4% remission is there. So exercise is widely recognized as one of the most important intervention for health, not only for health promotion, but also for the treatment of various medical conditions. And that's why it has been said that if a pill contain all the benefit of exercise, then it will have to be the one of the most widely prescribed drug in the whole world. So that's why exercise is so much important, and we have to know the principle of the exercise prescription, how to use that exercise as a medicine. So before going into the details, we have first to know the different physical fitness, because the aim or purpose of exercise is just to improve or maintenance of the physical fitness. Like physical fitness can be health related, cardiorespiratory, endurance, body composition, muscle strength, muscular endurance, flexibility. These are different component of the physical fitness. So and also sports related or skill related physical component, fitness component are there, like agility, coordination, balance, power, reaction time, and speed. So these are important not only for different sports, but also for the general people also. Like for example, balance and proprioception and coordination training is very much important in case of the elderly, in order to prevent the risks of the falling, and to fight the bad effect of the sarcopenia or sarcopenic obesity, where strength training, and improvement in the body composition, these are all important. So different exercise program can be designed in order to target a specific component of the physical fitness. So further going into the basic of the exercise physiology, what we can see that the overlapping bioenergetics or overlapping exercise energy systems one can know, because depending upon which energy system is predominant, we can classify exercise as a predominantly anaerobic or or aerobic exercise, and approximately based upon a percentage of the heart rate maximum, some approximate guess we can get which component is supplying majorly predominantly supplying to which exercise. For example, ATP PCR system is targeted mostly around 90 to 100% of the heart rate maximum, anaerobic glycolytic to 85 to 100% heart rate maximum, and aerobic training or aerobic exercise is mostly around 50 or 60% to 90% of the HR max, or in case of the VO2 max, it can be 40, 50 to 85% of the VO2 max, where heart rate maximum can be calculated by using this formula of 208 minus 0.7 into S in year. We don't use 220 minus S because this equation is not reliable at all. So based upon the different criteria, the aerobic exercise can be the intensity of aerobic exercise can be graded into like very light, moderate, vigorous to near maximum. For example, as per percentage of the heart rate maximum, 57, 64, 76, 99, 96, 96. That's all. You have to remember this number. So easily remember form, or based upon the percentage of the HRR or heart rate reserve, or VO2R, VO2 reserve, 30, 40, 60, 90, 90. Or percentage of the VO2 max, 37, 45, 64, 91, 91, or MET, metabolic equivalent of tax, 2, 3, 6, 8.8, 8.8, or rate of perceived exertion, 9 to 11, 12 to 13, 14 to 17, or 18. And similarly, resistant training can also be classified based upon 1 RM, where 1 RM is the repetition maximum ability to lift that particular weight only one time by maintaining all the form. That is 1 RM. The percentage of the one that maximum intensity. So you can classify your exercise intensity. Like for example, if my 1 RM is 100 kg, and if I am able to lift only say less than 30 kg, then I am doing very light exercise. So in that way, it can be exercise intensity can be classified. So easy to remember: 30, 30, 50, 70, 85, 85. So exercise grading based upon American College of Sports Medicine. Another point is the frequently asked question is how we can convert the VO2 max percentage or VO2 max reserve into heart HRR reserve or HR maximum. By using one carbonate method, we can do, which is mostly for moderate to high intensity exercise, where training heart rate, concept of the training heart rate zone or training heart rate can be done at a particular percentage of VO2 max. Suppose say Z% of VO2 max. Z% of VO2 max can be converted into heart rate by using, you have to remember the resting heart rate plus Z by 100 into this is the heart rate maximum heart rate reserve. So where resting heart rate you can calculate in the right in the morning before you go out of the bed after a restful good night's sleep, just after wake up from the carotid artery. Or if that data is not available, then you have to do a sufficient rest for say a 15-minute, 20-minute, or 30-minute, depending upon the requirement. So carbonate method can be used, and apart from the carbonate method, there are so many other equations which you can use. And this equation can be used to approximately convert, say, for example, 40 to 60% of VO2 max for 10 to 20 minutes, 5 minutes before the recovery is usually done for warm up. So warm up, 40 to 60% of the intensity can be converted into maximum percentage of maximum heart rate, and hence can be used practically. Similarly, for warm down, that is less than equal to less than 50% of the VO2 max, you can easily convert, by using the carbonate formula or any other formula. So 5 to 10 minute if next bout is required in 2 to 4 hours. So warm down is absolutely, we don't call cool down, we call warm down, because warm down is an important component. That's why emphasis is given by saying the word warm down. So going into the principle of the exercise training, you have to just to remember the word sports. S stands for specificity, principle of the specificity, SAID. It is also known as SAID, specific adaptation to the imposed demand, means your physiological adaptation will be depending upon which type of exercise you are giving. It has to be specific. And apart from the specific, there is also another principle of the individuality, where adaptation to the exercise or maybe individual variation may be there depending upon the different individual. Another is the progressive overload. In order to challenge your physiological system, then sufficient stimulus load should be given. Otherwise, adaptation will not be possible. That's why your exercise design should be such that it is progressively overload. Now, this progressive overload should be in the range up to the range of the overreaching. It should not go beyond overreaching, which is known as overtraining, where physiological maladaptation is happening and decreased performance is there. So overreaching is basically where progressive overload accompanied with right and adequate recovery. Then you can have something known as physiological supercompensation or physiological positive optimal adaptation is possible here. And this this progressive overload and other is is done in the way of the and this overreaching and overtraining balance is done basically by doing a variation or periodization of different method, like for example depending upon the phase of the training, like preparation phase or competition phase or other phase, your volume, intensity or technique training can vary. For example, in case of preparation, volume training is very very high as compared to the competition phase. So variation of or periodization can be done where daily, micro, meso, as well as the macro fluctuation can also be done. And this is the principle of the periodization, and the ultimate purpose is we want to reach the overreaching and optimal physiological adaptation and avoid overtraining. This is important. Another one is the reversibility, principle of the reversibility. Whatever you gain, if you don't give adequate stimulus further, then whatever you gain you may lose also. That is the effect of the detraining. So if you stop doing exercise, if the exercise intensity is or the volume or the exercise load is so much less that your body now goes into go back to the pre-exercise baseline, and all the benefits you may lose. This is the principle of the detraining. So we have to avoid the detraining. So in order, but we can still decrease the amount of the exercise load, but still a performance can be maintained, or in fact it can be little bit increased. This is the principle we use for tapering, where before the competition the tapering of the exercise load is done just before the competition, so that injury free performance enhancement can be done. Another important, as a physiology, as an exercise scientist, as a sports and exercise medicine, you have to remember, you have to know is how you have to identify this overtraining. Different techniques are there, but no particular technique is sufficient. You have to use combination of the technique. Like for example, HRV can be used like negative logarithm of the RMSSD, one of the time domain parameter you can use by using that. T by C ratio, testosterone cortisol ratio of less than 30 or less than baseline is mostly associated with overtraining or go beyond when you are going beyond the overreaching. And the most important persistently reported parameters which are associated with overtraining is decreased performance and persistent high fatigue or self-reported stress level and the sleep disturbance, or there may be decrease in maximum heart rate, or there may be certain changes in the blood lactate threshold or elevated resting plasma node in the epinephrine level. So depending upon various biochemical parameters, various physiological parameters, and the clinical assessment and psychological profile assessment, you may know that a particular person is going toward overtraining. This is important. After knowing the principle of the exercise training, one should know the principle of the exercise prescription. What we follow is the FIT BP principle, where F is the frequency, intensity, time. Frequency, how much frequently you have to give the exercise per day or per week. Intensity, how much intensity, which type of exercise you are giving, for how much duration you are giving, and volume. Volume is basically the intensity, frequency, and the duration. That is, these three are contained in the volumeter. So volume is how much load exercise load you are giving, frequency into intensity into duration. Another is the progression. Your exercise prescription design has to be progressive because it has to follow the principle of the progressive overload. So all these things you have to and also pattern how to follow, and what are the different specific guideline for a particular exercise. So you have to remember, and you have to design your exercise prescription in such a way that so the individualized effect can be there. So before going in details into the exercise prescription, we must first know, is there any medically associated health risks, or for exercise related health assessment is very important. Like for example, self reported physical activity readiness questionnaire, by using this to 2021 2021 per Q plus, you can easily done, or various guideline which has been algorithm which has been prescribed, you can follow. Like for example, if your the client is not doing any regular physical activity and there is no cardiovascular metabolic renal disease and there is no symptoms, then there is no need of medical clearance, especially for light to moderate exercise. And it may be progress slowly for as per the guideline into the higher intensity of the exercise. And for elderly population and for other population, medically physiologically risk subgroup that population, then it is always advised that you consult with a specialist exercise and sports medicine doctor, or exercise or sports physiologist. And if there is a known condition of the cardiovascular metabolic renal disease, even if asymptomatic, then medical clearance is recommended for moderate exercise, light to moderate exercise. For the person having that particular symptoms related, regardless of status of exercise, clearance is absolutely required. This is important. And if a particular person is have been doing regular physical activity, if there is no underlying cardiovascular metabolic or renal health, there is no symptoms, then medical clearance not required. Even medical clearance is not required for say a moderate to vigorous intensity exercise also, based upon the condition of the person. And if there is a known condition of the cardiovascular metabolic renal disease, even if asymptomatic, then medical clearance is required for moderate, may not be for higher intensity exercise, where for moderate intensity, may not be necessary, but it depends upon person to person. And for the person who are having symptoms suggestive or symptoms of cardiovascular metabolic renal health, regardless of the state of exercise, then it is always better to discontinue the particular exercise which you are doing, and better to do exercise clearance, then return to play or return to exercise should be done after the appropriate exercise clearance. So depending upon like similar algorithm, easily available algorithm, more easy user friendly algorithm are available, which you can use in your exercise training center or gym. But the point is, detailed history and medical examination is absolutely required, and they, based upon this finding, you can do 12-lead resting ECG, or which may, and if there is any requirement, you can do exercise stress test also, like, or Holter even monitoring can also be done. And depending upon the finding in the ECG and other, you can you can go into echocardiography or cardiac MRI led gadolinium enhancement test for the fibrosis detection or scarring of the myocardial scarring, especially post COVID. So these are all important. So depending upon the requirement, investigation can be done. So you must also know when to stop a particular exercise. So this is a guideline which was given by American College of Sports Medicine. It is just compiled. So it can be, yeah, like a general guideline. General guideline is also similar to also the relative indication for stoppage of exercise. Like for example, if there is anxiety or angina or angina like symptoms, it's better to stop the exercise. Or if there is a drop in BP of more systolic blood pressure of more equal to more than 10 millimeter of mercury, or excessive rise in blood pressure is there, like more than 250 millimeter of mercury, or diastolic more than 150 millimeter of mercury, shortness of breath is there, wheezing, cellular cramp is there, claudication is there, nausea is there. So all these things, these are the important. Or for example, in case of the ECG, there is a marked ST displacement in the form of the horizontal or down sloping of more than 2 mm, measure at 60 to 80 millisecond after the J point. In a patient who is suspected of the ischemia, it is always better to stop the exercise. Or if there is drop in systolic blood pressure, like I have said, more than 10 millimeter of the mercury, or shortness of the breath, angina, like arrhythmia, the arrhythmia condition may be there, or SpO2 drop may be there, equal to less than 80%, or drop in SpO2 of more than equal to more than 5% during the exercise. You may consider stopping of exercise. This is particularly important during the COVID time, where 6-minute walk test was used, and decrease in SpO2 of equal to more than 5% was considered that the disease, the pulmonary involvement and other involvement of these was little bit serious. And absolute, also there is also absolute criteria is there, indication is there for the stoppage, like for example ST elevation of more than 1 mm in lids without any pre-existing Q wave because of the prior MI other than AVR or AVL or V1, or similarly drop in systolic BP of more than this thing, and moderate and severe angina, sustained ventricular tachycardia, a sign of the poor perfusion. So all this thing is important. Another one is also, apart from the, see, apart, this is for we are focusing on systolic blood pressure, a drop in systolic blood pressure, but there may also be rise in diastolic blood pressure. Although sometimes the diastolic blood rise in diastolic blood equal to more than 15 millimeter mercury or 10 to 15 millimeter mercury, you may be very much get caution that your exercise may be terminated. Also, you may stop the exercise also, depending, because if you're doing isotonic exercise, diastolic blood pressure mostly remains stable, or it may little bit fall also. But sufficient increase in diastolic blood pressure, then you maybe then you have to be little bit careful also at that time. So going into the cardiorespiratory endurance basically done by different ergometer, like a treadmill or a bicycle ergometer, or it can be done by using what is called the indirect measure, like step test is there, different field test like a blip test is there, yo-yo test is there. So depending upon a different, directly measure incremental exercise protocol using gas analyzer, or using indirect different method, you can do. But what you have to remember is you have to understand the underlying biochemistry, underlying physiology, and for that, what you have to understand is that not only VO2 max, but also for anaerobic threshold, respiratory compensation point, and different other parameters are so much important. Like for example, you can see that like VCO2 increases, and this keep on increases after an anaerobic threshold up to and beyond the respiratory compensation point also. But when you see here, that is V by VCO2, or ventilatory equivalent for carbon dioxide, as well as the what you call the VO2 ET, VCO2 ET, that is the end tidal carbon dioxide, which is indirect measurement of the partial pressure of the carbon dioxide in arterial partial pressure of the carbon dioxide. They are relatively remains the same, and hence it is also known as isocapnic buffering, where the metabolic acid produced during the exercise is buffered by the increasing ventilatory threshold, ventilatory respiratory compensation is there. And beyond this point, what is happening is respiratory compensation is so much great that what is happening, there is a wash out of the carbon dioxide here itself. That's why the EtCO2 is falling, and that's why PaCO2, partial pressure carbon dioxide, also falls. Whereas if you see the V by VO2, that is ventilatory equivalent for oxygen, increases, as well as partial pressure of the oxygen it increases. So depending upon the different physiology, if you know the working of the physiology, if you know the underlying working, then you will be able to understand what is normal. You can identify what is abnormal from normal, and you can approximately guide into what may be the different causes of that exercise intolerance which you are getting in your patient. That's why. So this phase after respiratory compensation point, it is also known as HVV. That is hypocapnic hyperventilation. Hypocapnic is there, hypocapnia is there, but hyperventilation is there because of the hypocapnia is there. So HHV or hypocapnic hyperventilation phase, it is also known as HSV, or hypocapnic hyperventilation phase. So next, going similarly, what I said, that next going into the different component, because there are the different disease or different medical condition may affect exercise intolerance, which may affect because of the muscular system or cardiovascular system, or it may be because of the respiratory pulmonary system. So your aim is you can pinpoint a particular condition, which condition is causing to which, by using by the basic knowledge of the exercise physiology, and by following different algorithm. Like for example, if you identify the peak VO2, and if that peak VO2 is normal means equal to more than 85% of predicted, then it may be exercise intolerance, or maybe because of the anxiety, obesity, or mild, especially when RER is less than 1.1 or less than 1, because RER is less than 1 means what? Poor effort is there, anxiety may be there, or the disease may be mild. Or if the peak VO2 is less, then you have to see the anaerobic threshold, and depending upon whether it is normal or low, then, and also depending upon the breathing reserve, you can basically identify the serious condition. Like for example, low breathing reserve with normal anaerobic threshold in less weak PO2, maybe because of the ventilatory impairment, or the person with the low breathing reserve with low anaerobic threshold, with low anaerobic threshold and low peak VO2, maybe mixed lesion maybe there. So normal anaerobic threshold, low peak, what you call low peak VO2, and if the breathing reserve is normal, it may be coronary disease also, decongestion also, poor effort also. So likewise, you this algorithm may guide you into the different parameters, and similarly, different algorithms are also available. Like if you see the what you call there is decrease in peak VO2, that is less than 85%, that means it is low. If peak VO2 is low, and if the RER is more than 1.15, and you have to see the breathing reserve and normal spirometry. If the breathing reserve is normal, then you have to see the anaerobic threshold as well as the VE by VCO2. If the VE by VCO2 is high and anaerobic threshold is low, then you can say that there is a V by Q mismatch, or ventilation perfusion mismatch is there, or early anaerobic metabolism is being used by the patient. And if desaturation is there, then you can say that there may be pulmonary hypertension, or if desaturation is normal, then you can say that cardiac impairment may be there. Or if the BE by VCO2 is not more than 34, and if the anaerobic threshold is not less than 40%, and if there is no desaturation, then you can say that it may be because of the obesity, exercise intolerance, or this peak less than 85% is maybe because of the obesity or deconditioning. Similarly, if you see that there is a abnormal breathing reserve, if the breathing reserve is not normal, and if there is a desaturation happening during the exercise, then especially if associated with the high VE by VCO2 slope, then we can see that say that a particular person, the exercise limiting factor is because of the primary lung disease. So depending upon this basic physiological knowledge, you will be able to guide the clinician or on different diagnostic as well as management protocol. So this is the importance of the investigative clinical exercise physiology. Another important point which I want to highlight is high intensity training, because nowadays high intensity interval training are becoming very, very popular. Here you can see that as compared to the regular endurance, normally endurance training comprising of moderate, continuous exercise of say approximately 1 hour 5 times a week, a high intensity of around only 30 seconds, which is done 4 to 6 times, 4-minute recovery is given, and 3 times a week. The cytochrome oxidase activity, maximum cytochrome oxidase activity, after 2 weeks of training is same as compared to the traditional endurance training. Similarly, if we see the time trial performance improvement is there, and this proper decrease in time is there, and this decreased time is approximately same for HIIT and the traditional. But the point is, HIIT was performed only for 2.5 hours. That is less than 90% lower volume of HIIT as compared to the traditional. That's why you are doing less exercise, less volume, but still you are able to maintain that all benefit of aerobic training. In fact, some of the literature has reported more beneficial effect of HIIT also. And one can easily design an HIIT where the vigorous or near maximum intensity exercise can be done for less than say 45 seconds to 4 minutes, and it can be accompanied with equal or more, say 1 to 6 minutes of light to moderate exercise. And another point for HIIT is there is in case of the concurrent training. Concurrent training is when we use aerobic training as well as resistance training simultaneously. The problem of the concurrent training is sometimes we notice the effect of the interference effect, where the resistant, the adaptation to the resistant training maybe in the form of the hypertrophy, maybe in the form of the strength, maybe in the form of the power, it is affected negatively by aerobic training, traditional aerobic training, because of the secondary messenger for the molecular messenger for the aerobic training is going and affecting negatively the secondary messenger for resistant training. This is basically the interference effect, and this interference effect can be minimized if we avoid the traditional, slow and continuous, low prolonged aerobic training, especially running. If we substitute that by using high intensity interval training, especially by cycling, then we can minimize the effect of the interference training. And also, you can design it depending upon a goal. For example, if your goal is power, then concurrent training, you don't have to use concurrent training, because aerobic training has more negative effect on power as compared to strength or hypertrophy, because strength or hypertrophy concurrent training can still be used, but you have to keep the aerobic training less than 30 minutes, or say less than 3 per week, and the ratio of the resistant to aerobic training can be, say, 2 to 3:1. But for aerobic performance, resistance training has in fact positive effect on the aerobic performance. So there is the concurrent training is highly useful. There is no need of reduction. In fact, resistant to aerobic training, you can give 1 to 2:1, and for fat loss also concurrent training is highly recommended. So depending upon the different type of the protocol, you can design high intensity training into different category. Like for example, short interval you can give with walk duration of the equal to more than 50 seconds, and high at very high intensity of 100 to 120% of the velocity at VO2 max, and with a recovery of this are the with recovery of, say, less than 15 seconds, or equal to more than 15 seconds. It may be passive, the recovery may be passive, or you may do exercise at a less intense, like equal to or less than 70% of the velocity at VO2 max. So depending upon the different, you may design, like for example, a long interval you may design repeated sprint training, training, or game based training. So these are the important different types of the high intensity training regime, which you can easily identify. And another one of this high intensity is, since you are doing very less exercise, then you may be able to do exercise snacking. Instead of doing a long duration exercise once, then it will be better if you divide into smaller segment, and throughout distributed throughout the day. This is basically the concept of the exercise snacking. So going again to the principle of the resistant training, one has to understand, the goal of the resistant training. Suppose it may be strength, power. If you are focusing more on strength and power, then your maximum repetition has to be lower, because your intensity has to be higher. And if you are more looking toward muscular endurance, then your intensity will be lower, and hence your maximum repetition can be higher. Similarly here also, if you are going more into the repetition, then your intensity is lower, and you can focus more into the low intensity endurance zone. Similarly, for high strength and power zone, your maximum repetition has to be lower. So depending upon, just like what I have already told, depending upon the percentage of the 1 RM, the intensity can be gratified, like supramaximal for 100, more than 100, equal to more than 100. Like for example, very heavy 95 to 100, and very light maybe less than 60. So all this thing is you have to understand. Another point which you have to understand is the Henneman's size principle of different recruitment pattern of the different what you call the muscle fiber. Like type 2 fiber has a very high threshold, but that is absolutely required if you are performing a very high intensity, or if your weight is very, very high as compared to the type 1. So this all you have to keep in mind. And after that, you can you can make a protocol like what I have written here. Like for example, if your goal is for strength build-up, then it is always better to focus on the high intensity that is equal to more than 85% of the 1 RM, or 90 to 100% of the 1 RM. And since it is very high, the repetition has to be a little bit lower, rest interval has to be a little bit higher, and you can do 2 to 6 or 3 to 5 sets. And for power is nothing but force into velocity is power. Velocity component is there apart from the muscle strength. So power may be, say, a single joint event or multi-joint event. Like for example, it may be 80 to 90% of the 1 RM for single joint, 75 to 85% multiple joint. and relatively less repetition with relatively little bit higher of the rest interval. And or you may target to 40 to 60% of the 1 RM with a little bit of lower rest interval, because we are the intensity is a little bit lower, and the speed is by using explosive speed. For muscle hypertrophy, you can aim around 67 to 85% of the 1 RM, or 70 to 90% with it may be 6 to 12 or 8 to 12 repetition of exercise can be done, and set maybe 3 to 6 or 2 to 3, and the rest interval maybe say 30 to 90 second or 60 to 75 second. And slow, you do a more slow movement. Speed is slow in case of the eccentric component of the isotonic strength training. And for example, if you are more looking into the muscular endurance, then muscular endurance, the load has to be lower. Since the load is lower, then the repetition can be high, and since the load is lower, repetition is high, you can give the rest a relatively lower rest interval also, and depending upon the different sports, the speed can be controlled. So this is the principle for resistance training. And one has to know this thing in order to effectively prescribe exercise. So going again for different recruitment pattern and exercise selection, you have to understand that the recruitment of the different motor unit depends upon the Henneman size principle. This is the Henneman size principle, where the recruitment of the high type 2 fiber happens when they have a very high threshold is there, but they are recruited when high force generation is required, as compared to the type 1 fiber, that is slow oxidative fiber. And also the muscle activation, the percentage of muscle activation not only depend upon the intensity or load, that is tension, but it also depend upon the speed. For example, if you see for the same intensity at 5 kg, if we increase the speed from 0.1 radian per second, angular speed from 0.1 radian per second to 1 radian per second, you see that the graph is shifting upward and toward the here little bit toward the left side, and hence we can say that with increasing speed, angular velocity, and with increasing intensity or increasing load, your muscle recruitment or muscle activation, muscle fiber activation increases. So the basic knowledge of which particular muscle fiber recruitment is there in which type of the exercise by using surface EMG guided training, or you can give individualized particular exercise selection benefiting different type of the muscle group. Like for example, there are three variation for bench press. For incline, if you want to the focus on tricep, then you cannot give incline bench press, because incline bench press focus tricep activation is not much there as compared to the decline one. And in case of the decline one, the anterior, this is the decline one, this is the incline. In the decline bench press, the anterior deltoid activation is not much there. So depending upon your prior neurophysiological knowledge, neuromuscular physiological knowledge, exercise selection can be done. Another important for exercise selection for the use of the EMG is the EMG can also be used in order to understand, different muscle recruitment, different muscle activity also, which may not be the prime mover. For example, in case of the bench press, the EMG activity of pectoralis and deltoid is understandable because they are the prime mover. They basically what is happening, basically what they are doing is arthrokinetically they are pulling the head of the humerus anteriorly into the glenoid cavity. But there must be also dynamic stabilizer should also be there. This dynamic stabilizer is provided by infraspinatus. That's why EMG activity is high. So they basically contract in the same proportion in order to keep the head of the humerus centered in the glenoid cavity. This is extremely important. If you neglect strengthening of the rotator cuff, then what is happening is too much deltoid activation, then there may be impingement syndrome may happen, or subacromium versa compression or bursitis may also be happen. Supraspinatus impingement syndrome may happen. There may be painful arc syndrome, or if you do abductor abduction of the shoulder joint, pain may be there. So That's why exercise of a rotator cuff muscle is extremely important. Similarly, depending upon the different foot position, in fact, the muscle hypertrophy can also be controlled. Like for example, calf muscle hypertrophy. If you are pointing your toes toward outside here, like this toward outside, then you are targeting more of the medial part of the head of the gastrocnemius as compared to the lateral one. And for the lateral one, you are pointing. If you are pointing toes toward, then you are targeting more of the lateral aspect of the gastrocnemius. So just by knowing all the physiological basis, the selection of the exercise can be done effectively. Similarly, targeted exercise modification can be done. For example, here, in case of this squat, you can see that if your knee is passing beyond your toes, then some stress is always there in case of the knee. So if knee pain is there, so this form of exercise is not recommended. And you may change into this the other form of exercise. But the problem with this form is by using a reference tool, more load is being transferred to the hip and this spinal structure. So if their back pain is there, if the hip pain is there, then it will be more beneficial if you do this form of exercise. And how much one can go beyond the knees, beyond the toes, is approximately around 15 to 20 centimeter. If it is more than 15 to 20 centimeter, then it can be said that the load on the knee is relatively more. So as long as it is less than say 15 to 20 centimeter, there is not much load, and you can easily give such exercise in case of the, especially in case of the hip pain is there, in case of the spinal stress is there. Similarly, for a hip pain, sumo deadlift modification can be done. Like for example, if a sumo deadlift is done with a wide stance, increased toe, then it is more challenging for the hip. So hip pain, a patient may not be able to do this type of exercise. You may have to incorporate bar deadlift or conventional deadlift as compared to this one. Similarly, for the hip pain, the patient having say a femoral acetabular impingement syndrome, in case of the back squat, there is the hip is more stress is there for hip. So the person may or may not be able to do this form of exercise. You may incorporate more of the split squat or goblet squat or front squat as compared to the back squat, because they are less challenging for the hip muscle. So as per the requirement, clinical requirement, you can do exercise modification. Similarly, for running also, same thing you can do. For example, depending upon the base of the running, this is a rear foot strike running or heel strike running, where you're striking the ground with your heel first, and this is the forefoot strike or non rear foot strike. Here mid foot strike as well as forefoot strike is coming, and mostly we use non rear foot strike when we run barefoot or when we use minimalistic shoes. So one has to know all these things. But injury pattern also may differ depending upon which type of the strike pattern you are using. For example, if your knee problem is there, then here strike is a problem, because they causes more stress to the shin. MTSS, medial tibial stress syndrome, may be there. Knee pain may be there. Back pain may be there. So, or for example, what you call the tibial stress fracture, bone load, bone strain may also develop. But if you do more of this exercise, then what has happened? You may end up having what you call the ankle problem, foot problem. That's why the intrinsic muscle strengthening exercise is extremely important, as well as the eccentric exercise training for gastrosoleus muscle and Achilles tendon is absolutely important if you want to go to non rear foot strike, or if you have any metatarsal problem. Metatarsalgia may also be, sometimes some patient may develop or Morton's neuroma also. So depending upon the which type particular exercise, which particular problem, you have to modify. But one thing is very certain, that in order to changes from one running to another running, it has to be very slow, it has to be very gradual, and it has to be accompanied by a sufficient strengthening and conditioning of the the structure which may be at risk. So that's why it is extremely important. Another point which one has to remember as far as running is concerned is the vertical ground reaction is approximately proportional to the velocity of the running. If you increase the velocity, vertical ground reaction will be more. Like for example, if you're running at a very high intense speed of 25.2 kilometer per hour, then 3 times your body weight, your musculoskeletal structure may be bearing may have to face this amount of force. And approximately on an average, running causes around 2.2 body weight of vertical ground reaction force, which is twice more than that which you encounter during the walking. And hence, if a particular person is overweight, obese, having different problem, the different musculoskeletal condition, then you may prescribe running, walking first, then slow jogging, and then slow running before going into progressive into high velocity running. Like for example, slow running using the methadone, MAF, yeah. Maximum aerobic function training is widely used, where training heart rate is the higher training heart rate is 180 minus AS in year, or you may subtract 5 to 10 or 8 10 beats per minute depending upon your condition. And the lower range is this 180 minus is minus 10 for lower range. So this basically what you are doing is you are basically doing moderate to low to moderate and little bit less vigorous intensity of the exercise, where your enhance your ground reaction force will not be that much high, and you are more focusing on non-rear foot strike, morely toward mid-foot or forefoot, depending upon how whether you're habitual for that or not. And also, since it is relatively lower exercise intensity is there as compared to the sprinting, then your cardiovascular system will be able to deliver oxygen more effectively, and hence you will be more able to burn more fat. The fat burning may also be there. But one has to remember the principle of the specificity. So if a particular person has to train specific for a sprint training, then sprint training has to be there, not a slow running. So this one must understand. Now let's go to the another principle of eccentric training, where eccentric training is basically the stretching of the lengthening of the muscle while the muscle is still contracting. This is known as eccentric training. Contraction and shortening, they are not equal. Contraction and shortening is the concentric isotonic exercise. Contraction plus lengthening is the eccentric isotonic exercise. And eccentric training form an important part of the plyometrics and what is also known as SSC, stress shortening cycle. What is stretching here? Eccentric contraction is there, then it is followed by concentric contraction. If you do in this manner, then the amount of the force or power or performance output by the subsequent concentric exercise significantly increase. So this form the basis of different sports, various sports and plyometric. Like for example, jumping is for example the counter movement jumping is there. So before the jumping, you basically bend your knee, flex your knee, and you do stretching, eccentric, stretching of your quadriceps muscle, and this is the stretching. Then followed by concentric contraction of your quadriceps muscle, resulting into your explosive vertical jump. And this performance is higher because of that eccentric stretching is there. This is where this SSC is an important component in various sports. So one has to understand. Apart from SSC, eccentric training is also absolutely important for muscle gain. See, as compared to the concentric, eccentric favor the muscle gain, and it can also be used for elderly population. Even like for example, here in this study, they have used compared eccentric as well as traditional, more eccentric and concentric training for by giving 11 week. You can see that there is improvement in the strength, and improvement in the strength is more in case of the eccentric, and also fiber cross sectional area is increases after eccentric training. So eccentric training is absolutely important. But there is one problem of eccentric training also, which one has to understand. And for this, you have to understand the basic neurophysiology of the eccentric force, what we call velocity curve. This is the force velocity curve of the eccentric. This is the eccentric part. This is the concentric part. In the concentric part, you can see that as the velocities increases, then what is happened? Your force is decreases. So there is the inverse proportional between the velocity and force. But however, in case of the eccentric part, you can see that if if you increase the velocity, then your force also increases. The force also increases. So there is a direct proportionate between the force and velocity. So if you see this part only, and if you zoom out and represent this part, and if you see this exercise where leg press is there, incline leg press is there. So what is happening is, if you are pressing the weight, then then what is happening is there causes contraction, concentric contraction of the quadricep muscle. But when the same weight is decreasing, then what is happening to the quadricep muscle? There causes eccentric contraction of the quadricep muscle. So what is happening is, you are, suppose if you are following this curve, let's say if you are following this strength curve in the concentric part, when you are pushing the weight upward, then this is your strength curve. Then but if you are doing eccentric also, and for eccentric using the same weight, then your activation has to be reduced, because same, in order to maintain the same weight, because same weight is being lowered down. That may, because you cannot stay on this force velocity curve, because if you want to stay in force velocity curve, then the force has to be higher in order to achieve the same activation in eccentric. But since we are not using the same way, unfortunately the activation has to be lower. So this is practically we can see in various type of the strength training device modality which we are using. Like for example, here you can see that in the concentric, this is the concentric part, this is the eccentric part. Concentric part, this is the EMG pattern, surface EMG pattern, interference pattern is there. But in the eccentric part, see, significant decrease is there in the EMG. That means activation is decreases. So how to overcome this problem? This problem can only be overcome if you stay on this force velocity curve. And in order to stay on this velocity curve, you have to increase the force. If you, because force is more force is there, so you have to increase the force. So if you increase the force in the eccentric part by say 1.5 times the load which you are using in the concentric part, then there occurs more 30% more drive, EMG drive, and the EMG in the eccentric may be approximately similar with that of the concentric training. So by using variable resistance training, where the load of the resistance training varies depending upon which phase you are using, either concentric or eccentric, or by using isokinetic dynamometer or other various other marketly available instrument which increases the load during the eccentric part, you are able to achieve the higher activation even in the eccentric training. So this is important, and just by knowing this basic neurophysiology, you can pin out that there are certain problems with the traditional training and certain modification is required in order to achieve the overall activation. Because the primary aim is you want to achieve the activation of all the motor unit, different types of motor unit, type 1 as well as type 2, and different component. So this type of concept is important. Next, going to the clinical applied aspect of the eccentric training. This is the basically the force length tension relationship or force tension relationship, and here is the what is the plateau phase or optimum phase where myosin overlapping is there, and hence the maximum force active force production is there. But as you keep on lengthening the muscle, what is happening is the contribution by the passive force increases as well as the contribution by that active force decreases, passive force increases. It is mainly by the titin, the the muscle protein titin. So what is happening is, if you do more of the eccentric training, then eccentric training will cause a specific adaptation in the particular muscle, like it increases the muscle length of the muscle fascicles, and where sarcomere increment is there in series as compared to the concentric training, where sarcomere they are increment in the width, or parallel increment is there in case of the sarcomere. So if you do eccentric training, then this whole curve may be shifted right side. That means you are able to achieve this the maximum active force at a higher longer length of the muscle. Why this is important? This is important because in order to prevent various sports injuries, So eccentric training is absolutely required in that particular, because at a lengthened position also, if you are able to do more active force generation, then protective effect is there against muscle strain and other sports injuries. So this concept one has to remember. Like for example, we are doing Nordic hamstring curl. Nordic hamstring exercise is an eccentric exercise for this hamstring, and it has been shown to be extremely useful for prevention as well as for the advanced rehabilitation phase, where just before the sports specific exercise, where you want to prescribe this kind of the exercise in the advanced rehabilitation phase. And eccentric training along with the concentric and isometric strength training is absolutely required for sports injury reduction. Like for example, a 69% reduction is there in sports injury by strength training. So not only for the hamstring, there are other exercises, like for example, if you have adductor strain, prevention as well as advanced rehabilitation, Copenhagen adductor exercise you can use. And if you are using if you are having the patellar tendinopathy, patellar tendon pain is there, jumper's knee, then you can do a rehabilitation by using decline board squat, decline approximately at the angle of the say 20 to 25 degree. Or if you are having mid insertion, patellar tendon, what do you call, the Achilles tendinopathy, then you can use eccentric exercise. Alfredson hill drop exercise can be used for gastrocnemius as well as soleus. If you bend the knees, it will be for soleus. If you not bend the knees, if you strap the knees, then it will be for gastrocnemius. So different exercise protocol one has to know and one has to master. And the effectiveness of the exercise protocol is basically because of what is known as the mechanotransduction. So mechanotransduction is basically what is happening is the exercise, especially the eccentric exercise and other, they cause a sliding of the collagen to one another. This sliding of the collagen will causes increase intercellular communication via gap junction, and there is also communication with the nucleus, and hence there occur more transcription and translation of the protein, and this will lead to the regeneration and medical effective therapy by using exercise. So this is the principle of the mechanotransduction. Like for example, here is the Alfredson hill drop protocol is being used for soleus, and this eccentric training is being done where mechanotransduction is applicable here. Similarly, for neurons also, nerve also, you can do different nerve stretching, nerve flossing exercise. In case of the flossing, you are increasing and decreasing the intensity, your tension along the nerve. That's why they are also known as slider and tensioner. Like for example, this is basically then for the radial nerve, and you can do for a median nerve. So this is basically he is doing for the median nerve, and this yellow band approximately mimicking the nerve, and this is basically the ulnar nerve. So also for the lower limb also, like sciatic and all that nerve, you can use different tensioner, slider, neural stretching as well as flossing. Like slum exercise is there, slum test is there, or modified Thomas test is also there. Modified Thomas exercise is also there. So these are the muscles as well as nerve. Apart from that, you have also to know the importance of the palpating, the beauty of the human feeling, human palpation. And this you can identify by using by just remembering star. Star is a sensitivity or tenderness. If you palpate the patient, the musculoskeletal system, whether there is a painful, sensitive or not, tenderness is there or not, tissue texture you have to feel. You have to feel for a taut bend. If there any taut bend is there, taut bend may be accompanied with active trigger point, or it may be a passive trigger point also with referred pain somewhere, or there may be asymmetry of both sides of the asymmetry may be there. There may be changes in the range of motion may be there. So depending upon this clinical examination, basic clinical exam, as well as there are different tests, you can basically identify the muscle imbalance. Like for example, this is the muscle imbalance which is given by Dr. Janda, and this is the upper cross and lower cross. Upper cross is if there is any problem in the neck region, then upper cross syndrome may be present. In case of the upper cross, what is happening is deep cervical muscle as well as lower trapezius and serratus anterior muscle they are weak, inhibited, and lengthened, and that's why you have to give strengthening of this muscle. Whereas the sternocleidoid mastoid muscle, sternocleidomastoid, pectoralis muscle, pectoralis major muscles, and upper trapezius and levator scapulae, sorry for the spelling mistake, they may be facilitated or tightened, and that's why you may stretch this the tightening. You may counter this by different stretching and different type of the exercise intervention. Similarly, for low back pain or low back problem here, lower cross syndrome may be present where strengthening may be required for abdominal muscle, transverse abdominal muscles may be required, gluteus medius, minimus, maximus strengthening may be required, like re-education, increased activation of the multifidus is also may also be required in addition to the transverse abdominis, as well as stretching of the rectus femoris or quadriceps muscle or iliopsoas muscle may be required, or thoracolumbar extensor stretching may be required because they are facilitated or tightened. So depending upon this different muscle imbalance which may be present, which you may diagnose and you may give exercise based upon the presence of various muscle imbalance. But one has to remember that this practical may not be similar as a theory. Janda's muscle imbalance may or may not be present, and most of the time it may not be accurate also. But and many of the muscle imbalance may not be present as it has been predicted in the theory. So that's why clinical and practical knowledge is extremely important. So after knowing all this component, then you can go ahead with the rehabilitation concept where you focus on muscle conditioning, like motor activation, re-education of that particular system, muscle system, group of muscle or particular muscle is required. You may focus on strength training, power and muscular endurance is also required. You may focus on range of motion exercise, flexibility training by using different stretching or muscular coordination, balance and proprioceptive training you may incorporate by using rocker ball or physio ball, or unstable environment by close eye, single leg, all these things. Functional exercise, you may incorporate certain functional exercise, or sports specific exercise has to be incorporated. And if there is any kind of the biomechanical abnormality, then you have to identify and you have to correct so that future recurrence may not be there. But one thing which you have to remember is there is no ideal biomechanical system is there, ideal posture or ideal stuff is not. It may be individualized. For example, one biomechanical abnormality may be present in an individual without any kind of the problem, with enhanced with good performance also. So you have to think about that, and that biomechanical abnormality may be a result of abnormality somewhere in the kinetic chain. So whole examination of the kinetic chain is important just before prescribing some orthotic or correcting that biomechanical abnormality. The functional biomechanical abnormality you can correct by having the knowledge of the clinical neuromuscular physiology and exercise therapy. And for other abnormal or fixed or bony biomechanical abnormality, you can do by using different intervention, including the surgery. Another important which one has to remember that you have to focus on the cardiorespiratory fitness also by using cross training and different other incorporating different other component in the rehabilitation itself. Also different psychological intervention one has to incorporate, like for example, say like after ACL reconstruction or after having some problem, then kind of so phobia may be one of the major hindrance where the fear of the movement is there. So psychological counseling, psychological intervention is as much as important as the physical intervention. And this physical intervention not only include the exercise like isometric exercise, isotonic, and then concentric isotonic, then eccentric isotonic concentric, which may be accompanied by sports functional and sports specific. But you have to focus on a cardiorespiratory fitness and aerobic fitness, aerobic build-up also. So going next to the another concept where the knowledge of the neurophysiology is absolutely important is the exercise associated muscle cramp. Here in the exercise associated muscle cramp, like for example, what is having is she is having the cramp of the quadricep muscle, and because of the quadricep muscle, or here the most common site is the calf muscle. So the now why this is happening? This may be happening because of the increased activation of the muscle spindle and a decreased activation of the Golgi tendon organ. Like what is happening is, if you see the basic neurophysiology, you can see there the muscle. This is the muscle spindle. The muscle spindle by 1B. Sorry. This is the muscle spindle. Muscle spindle by 1A fiber from the muscle spindle. That is directly activating the alpha motor neuron of that particular muscle. So muscle spindle is activating the neuron. That means increased activation of the muscle spindle will causes increased contraction of the muscle. Whereas in case of the Golgi tendon organ, and then 1B fiber from the Golgi tendon organ is stimulating an interneuron which is inhibiting the motor neuron. That means stimulation of the Golgi tendon organ is associated with the relaxation of the muscle. What will happen if there is increased activation of the muscle spindle, whereas decreased activation of the Golgi tendon organ? It will be associated with the uncontrolled contraction. So this is the pathophysiology of the exercise associated muscle cramp, and it is mostly generated by a premature fatigue. So how you are going to counter by knowing this knowledge of the neurophysiology? Just do stretching. Why stretching? Passive stretching of say up to 20 minutes or till the fasciculation stop is important, because passive stretching, what it will activate the Golgi tendon organ. Now this Golgi tendon organ, by the concept of the auto inhibition, this will ultimately inhibit that particular muscle and a relaxation will happen. Or you can do reciprocal inhibition also. Reciprocal inhibition, she is doing a stretching of the quadricep. So stretching of the quadricep is very much important for exercise associated muscle cramp. Or if you are having the problem in the quadricep muscle, then if you do contraction of the antagonist, what is the antagonist muscle for quadricep? Hamstring. So if you do contraction of the hamstring, then there may occur relaxation of the quadricep muscle because of the reciprocal inhibition. So reciprocal inhibition you can use, and during the stretching, some icing, it is advisable. You can do some icing, because this will offset the possible development of the DONS, delayed onset of the muscle soreness, later on. And certain electrical tendon afferent stimulation can also be done, which may increase the activity of the Golgi tendon organ. So this is the this was a book compilation which we wrote when I was working as a sports medicine doctor, specialist in Sports Authority of India. And if anyone is interested, then I will be very happy to share. So going next to the principle of the different type of the stretching where neurophysiology is used, is when we do the concept of the PNF, that is proprioceptive neuromuscular facilitation. What do you mean by proprioceptive muscular neuromuscular facilitation, and what is the neurophysiology? Absolutely beautiful. So before going into the basic neurophysiology circuit, what you have to understand is, in case of the suppose say if you want to do a stretching of the hamstring, then the particular person will be doing stretching for say 10 seconds up to that limit. Then going beyond that limit, then you have to do something which causes a relaxation of that particular muscle which you are stretching. The muscle which is being stretched, it is known as antagonist here in this context. The muscle being stretched, it is known as antagonist. The muscle which is opposite to the muscle being stretched is agonist. So agonist is the quadricep here, antagonist is the hamstring muscle, and we are doing antagonist. Relaxation of the hamstring is required. So relaxation of the hamstring can be done if you do isometric contraction of the hamstring. This is known as hold. If you do isometric contraction of the hamstring, then what will happen? There will be activation of the Golgi tendon organ, and this Golgi tendon organ will causes a relaxation of the muscle. And if relaxation of the muscle is there, then you may be able to stretch more. So that's why 6 seconds of the whole of this antagonist isometric contraction of the antagonist is done, followed by 30 seconds of the stretching by the partner. This is the whole relaxed PNF stretching. Another form of the PNF stretching is when you do, instead of the isotonic, if you do instead of the isometric, if you do isotonic contraction. This is known as contract relax PNF stretching. In case of the contract relax PNF stretching, what is done is you are doing isotonic contraction of this hamstring for say 10 seconds, followed by 30 seconds of the stretching by your partner. So similar principle, same principle of the autogenic inhibition by the Golgi tendon organ. Another one, if you may combine the concept of reciprocal inhibition also. Here, if you do the simultaneous contraction of the opposite muscle, here the opposite muscle is the agonist here in this context, that is quadriceps. If you do the contraction of the quadriceps, then what will happen? Hamstring will be relaxed by reciprocal inhibition. So this is basically the whole relax with agonist contraction PNF, where 10 seconds of the stretching is done. After that, by the partner, after the 6 seconds of the isometric contraction of the hamstring is done, which will cause us a relaxation of the hamstring by autogenic inhibition. Then 30-second contraction of the opposite muscle, that is quadriceps, is done along with the stretching, gentle stretch by the partner. And because of the reciprocal inhibition, you may be able to achieve more range of motion. So this is important. So this is basically the neurophysiological circuit for this type of the PNF stretching. Here you see that this is a Golgi tendon organ and different joint, cutaneous as well as joint receptor. They are basically going and activating. They are basically activating the interneuron, and this interneuron it is an inhibitory one, and this inhibit the alpha motor neuron of that particular muscle, and hence autogenic inhibition is happening. Autogenic inhibition is happening by whole means isometric contraction, and contract means isotonic contraction of the antagonist, here in this case hamstring. Another one is the reciprocal inhibition. How reciprocal inhibition happening? See, if you see the descending pathway here, all the descending pathway, they are giving collateral, one to the motor neuron which is supplying to the muscle, and another to a particular inhibitory motor neuron, which is this inhibitory interneuron is supplying, inhibiting the motor neuron of the opposite muscle, and opposite muscle will relax. So if you want to relax this opposite muscle, what you have to do? You have to do contraction of this muscle. And if you want to relax the hamstring, what you have to do? You have to do the contraction of the quadriceps. That's all. So this is the principle of the reciprocal inhibition. So that is the importance of the neurophysiology. If you understand the neurophysiology, if you understand the detailed basic physiology, then you may adapt, you may modify a particular exercise based upon your requirement for the, and in order to increase the. Similarly, different exercise as well as so the soft tissue and manual intervention can be addressed to correct the muscle tightness. Like for example, if you see the erector spinae tightness is there, then you can do self stretching can be done, or it may be assisted by a partner, or myofascial release can be done, where you apply pressure by with the hand, your hand, or by using assisted different tools are there, where tool assisted myofascial release is there, by using digit also, like digital pressure can also be used for, or ischemic pressure can also be used to correct the what you call the trigger point. You can use your elbow also. So depending upon what type of the things we are using, you can do myofascial release and you can correct the muscle tightness. For Schwarz also you can do like modified or Thomas position you can do, or you can do stretching myofascial release in this position, or iliotibial bend, ITP bend syndrome is also a friction syndrome is also mostly encountered in case of the distance runner or kick the one who kick. So ITB tightness may be there, tightness of the fascia lata and iliotibial band, where stretching self-directed, self-exercise can be done, or myofascial release can also be done. If you want to do solely stretching, then you can do by using the bending of the knee and stretching like this, or you can do your therapy, or your physician or your physiologist can do different, manual therapy or soft tissue therapy. Similarly, for different type of exercise, like for example, the hip external rotator, you can basically use the different type of the regimen. For hamstring also, same thing. For rectus femoris and quadricep stretching also you can do this type of thing. And for gastrocnemius also you can basically see the thing is there, and the leg is there is bending is not there in case of the knee. So this is the difference between soleus and gastrocnemius, because soleus doesn't cross the knee joint, but gastrocnemius cross the knee joint. So after knowing the basic therapeutic intervention, but you as a sports and exercise medicine physician or a sports and exercise medicine specialist or physiologist, what you have to understand that the exercise has also carries the potential for adverse effect, injury in the form of injury or illness. Like this is the if you increase from sedentary to physical activity, then the benefit of exercise also increase, but there is also increase in risk and harmful when excessive exercise is being done without any appropriate conditioning or appropriate recovery. But the good thing is the current guideline, if you are doing exercise more than the current guideline, that is also no problem, because the health risks, abnormality, health adverse effect may be even reduced if you do exercise which is more than the exercise prescribed by WHO or various American College of Sports Medicine, various society, because the current guideline is much higher above in this graph, where exercise and the health risks is there. So it is basically a U-shaped curve. And if there is a excessive high training volume or intensity of exercise is done, then extreme exercise hypothesis is there, when there may be adverse abnormality, adverse effect because of the exercise, and this one has to know. And for example, for injury purpose, you have to identify the sweet spot, and sweet spot can be identified by using the principle of the ACR, that is acute chronic workload, where the acute workload is the workload basically just done in the previous week, in the form it is basically synonymous as the fatigue, whereas chronic workload is the average of the previous 1 month or 4 weeks. This is synonymous with the fitness. So you want to increase the fitness, you want to decrease the fatigue, so a particular ratio of A by C ratio is used, where ideal ratio is around 0.8 to 1.3. If the ACR ratio is more than 1.5, then there is always the risk of the injury, and that's why it is known as the danger zone. And apart from the exercise injury, illness is also important, where especially for infection related problem, because the immune system and exercise, the immune system follows the inverted U-shaped curve, where at sedentary as well as the overtrained subject, the immune system is the impairment of the immune system may be there. So immune system abnormality is there. This is basically important in case of or viral infection in COVID time and different upper respiratory tract infection, which you have to understand. And for that purpose, if you want to do exercise prescription along if in presence of a medical illness or infection, then you have to know the neck check principle. Neck check is a rule of thumb. It may not be appropriate or valid for COVID case, but for most of the general condition, it gives a rough guide. For example, if your symptoms, if your infection, if your upper respiratory tract infection, the symptom is confined below the neck, like you are having muscle cramp, myalgia is there, you are having high grade fever is there, then it's always better to avoid exercise. It's always exercise. Or if your heart rate is more than say 10 beat per minute, then it is always better to do avoid the exercise. But you can see that in a very mild temperature, a light exercise may have a beneficial effect also. Another is if the symptom is confined to the above the neck, like for example, running nose is there, mild headache is there, then you may do exercise in a very mild to moderate intensity can be done. For example, you may decrease the intensity into half for 10 minutes, and then slowly can be increased, and the intensity has to be less than 70% of the HR max, that is heart rate maximum, or 80% of the VO2 max, and you have to focus more on the skill training. So this is the basic concept of the neck check. Another one which you can see here, so it is basically this curve is there. So if you sometimes some of the author has also prescribed the one curve which is known as AISSEM curve, where the risk of the infection the risk of the infection is higher in case of the sedentary. If you see the risk of the infection is this one. So if the risk of the infection is higher in case of sedentary, and a risk of the infection can be higher in case of the overtrained, but in case of the elite player it may be lower. So a particular ASSEM curve has also been described by different authors, where elite level players has where they are doing most of the high volume and high intensity exercise, and since their body is well trained as well as more adequate recovery is there. So in that case, their disease susceptibility may be lower. So it may be not the JSFET, but it may be more SFET curve. So next, going into the basic about exercise cardiac physiology. So in case of the exercise cardiac physiology, what we have to remember, what I want to focus is a condition known as Fidifits cardiomyopathy. Fidifits cardiomyopathy is mostly happens in case of the long endurance runner like marathon runner, where strenuous exercise, after doing external exercise, what is happening is there is because of the different catecholamines, increased demand, preload and afterload, and volume overload is there, and different different enzyme like troponin C, troponin CKMB, BNP may be raised if you measure just after marathon in those individuals. So if this strenuous exercise continues without any recovery, for a very long time, then it may related to the result into the acute effect, like for example right heart strain may be there, right atrium or right ventricular dilatation may be there, hypokinesia may be there, diastolic dysfunction may happen, and this may accumulate into some acute effect where there is increased expression of the cardiac fibrotic marker like TGF-B1, and increase the expression of the ECM like fibronectin 1, collagen MMP2, TIMP1. And because of this effect, there causes, what is happening is the patchy area of fibrosis you may develop in the cardiac heart fibrosis, scarring of the heart may be there. And since patchy area of the fibrosis is there, then it may be arrhythmogenic also. You may develop atrial arrhythmia. It may ultimately result into ventricular fibrillation, and ventricular fibrillation is very dangerous for sudden cardiac death. Sudden cardiac arrest may happen, and sudden cardiac death may also occur. So this concept is very important. So you have to maintain training where the training and you have to give sufficient recovery, where this cycle you have to break this cycle by giving a sufficient recovery and sufficient healing of the strenuous effect of the high intensity high load exercise. That's where this is basically the pathogenesis of the pathophysiology of the Fidifits cardiomyopathy. The one thing which you have to remember is the patchy area of the fibrosis. So catching patchy area of the fibrosis by using cardiac MRI, lead gadolinium enhancement is therefore extremely important. And similarly here, this is from the basic physiology, where this Frank-Starling curve is there, and in the Frank-Starling curve, stroke volume divided by end diastolic volume is nothing but the ejection fraction, and this they may lead to the disruption of the stretching, and the disruption of the myocardium fiber may happen, and this may lead to the shifting of this curve into more toward down or in the right side. This happens in different pathology, but this may happen in case of excessive workload, and it may result in the derangement of the the systolic as well as diastolic dysfunction. If ventricular and diastolic volume is decreased, then diastolic dysfunction may be there. If ejection fraction is decreased, then it may be systolic dysfunction may also occur. So this is important. So one practical aspect of which I want to focus is regarding the red pressure product or double product. Red pressure product is systolic blood pressure into heart rate. It is approximately equal to the oxygen consumption or oxygen demand by the heart. Oxygen demand by the heart depends upon the stroke volume, depends upon the pumping capacity of the heart. That is depend upon what you call the tension developed at the heart. Also, it is depend upon double product or RPV. That's why you have to focus on exercise which decrease diastolic double product or red pressure product, in case of the highly risky individual in when you are doing a prescription of the exercise. So this is important. So physiological adaptation of the heart is also there, and you have to differentiate between physiology and pathology. In case of the physiological adaptation, we generally encounter two: eccentric hypertrophy and concentric hypertrophy. Eccentric hypertrophy is basically happens where volume overload is there in case of the endurance training. Concentric hypertrophy is mostly there because of the pressure overload, and this happen in case of the what you call the strength training or resistance training. And these are a different the guideline, different adaptation may be there, and which is also known as athlete heart. And but the important of the athlete heart is, if you see the septal thickness, it rarely increase more than 50 mm. And if you do detraining is if you stop training for say 3 months. 3 months deconditioning or detraining is associated with 2 to 5 decrease in septal thickness. This is not present in case of the pathologic remodeling or pathologic hypertrophic cardiomyopathy or cardiomyopathy. In case of the hypertrophic cardiomyopathy and cardiomyopathy, you can see that the left ventricular end diastolic capacity is very much decreased. But however, left ventricular the dimension was more than 55 in case of the athlete heart, but here it is less than 45 that is diastolic dysfunction may be there. That's why diastolic dysfunction. So and this septal thickness is usually, most of the time, it is more than equal to or more than 50 and it is rarely less than rarely exceed 50 in case of the athlete heart. So and the effect of the deconditioning is not there in case of the pathologic heart. So you have to understand which one is athlete heart, which one is pathology heart. And there are gray zone also, where wall thickness from 13 to 15 in case of the male, and 12 to 13 in case of the woman, it has been considered to be in the gray zone. So you have to understand the physiological adaptation heart, like for example the athlete heart, the endurance trained athlete with a high with a larger end diastolic volume may have more vagal tone, and hence reduction of the resting heart rate may be there. So resting bradycardia may be there. But if the bradycardia is more less than 30 beats per minute, then you should investigate because it is rarely less than 30 beats per minute. This is what you have to understand. And this hypertrophic cardiomyopathy is why this is important, because hypertrophic cardiopathy and cardiomyopathy and other congenital condition, they are the leading cause for the sudden cardiac death in athlete who a younger athlete, less than 35 years. And if it is more than 35 years, coronary artery disease, they are the most of the leading cause of the death, sudden cardiac death. Like congenital artery abnormalities, Marfan syndrome may be there, aortic. These are the common syndrome. The other, like myocarditis. Myocarditis. I will be speaking myocarditis, post-COVID myocarditis, because many a times post-COVID myocarditis has been concerned. And aortic stenosis. These are the less common. Prolonged QT syndrome. Prolonged QT is also happening. Different of the drugs which were used without any evidence in terms of the COVID, like SQC, hydrochloroquine, and other drugs, and other antibiotic, which may causes prolongation of the QT syndrome, dilated cardiomyopathy, and coronary artery disease. So and conduction abnormal, like WPW syndrome, Wolff-Parkinson-White syndrome, Brugada syndrome. So all these things which you have to keep in mind, and you have to understand before going into the management part. So that's why, since most of the sudden cardiac arrest and sudden cardiac death in athlete is electrical abnormality, and a ventricular fibrillation is the most important resulting into the death of the athlete. That's why the training into CPR, that is a CPR with a compression first. Compression has to be given first, and if at all, if you are breath by breath, breathing Then an autonomic external defibrillator, AED. So training into AED is absolutely important, absolutely required for all the health professional or all the coaches and the player themselves also and relative also who are dealing with physical activity and exercise, and AED should be available in public, in various public platform, because the more quickly you do all these things, then there is always better chance of survival. I have written a chapter on the defibrillator, which is available in EPG Pathshala as a part of the physiological biophysics. If anyone is interested in the details, they may go there in the website, or they may see in the YouTube also. Going into the clinical cardiac pathophysiology, again, let's go into the concept of the atrial fibrillation. Atrial fibrillation is one of the most common cardiac arrhythmia in athlete, especially in middle-aged athlete, most of the time in case of the endurance player. So this is the atrial fibrillation, and this atrial fibrillation may be because of the different cardiac remodeling like atrial dilatation, adrenergic activation, vagal tone, more vagal tone is present in case of the athlete, and more vagal tone associated with high sympathetic stimulation. This is not good. This is not good for atrial fibrillation. And there may be a fibrosis, which I have just like in a Philippines cardiomyopathy, arrhythmogenic fibrosis may be done, and this fibrosis they may give accessory pathway, like in case of the bundle of Kane, in case of WBW syndrome. So these are the potential the causes of atrial fibrillation, or they are mostly present in the younger athlete also. The younger means in the sense of less than 55 years. So younger, or or 55 is mostly middle age athlete. And this athlete, we have to understand that the atrial fibrillation, the athlete have a higher risk of atrial fibrillation as compared to non-athlete. The odds ratio is 2.46. Though athletes are in fact, they have a higher odds of having atrial fibrillation, and they are mostly present in case of the endurance sports, or it may be mixed sports. These are the different associated condition: fibrosis, inflammation, cardiac remodeling, genetic predisposition may be present, or trigger event may be there, like atrial ectopic may trigger it, or some banned substance or illicit drug or sports supplement, like sympathomimetic. They may predispose, for atrial fibrillation, or it may be modulated by autonomic activation, electrolyte imbalance, acid reflux disease. So all these conditions may causes the presence of the atrial fibrillation in athlete. And if you want to see the basic pathophysiology of the athlete, you have to understand the electrophysiology and the basic cardiophysiology. Here you can see that this is the the VM. VM is nothing but a membrane potential. C is a calcium transient. So if when acetylcholine is given, acetylcholine is nothing but a vagal stimulation. The vagal stimulation causes reduction in the APB. There is action potential duration. It decrease. Action potential duration is decreased. I am talking about atria. Vagus system has vagus nerve has a differential activation to atria versus ventricle. Vagus causes this APV decreases in case of the atria myocyte, but in ventricle it doesn't cause. So this one has to remember. So it also causes decrease in height of the calcium transient. Now this vagus nerve, when vagus tone, an athlete, an endurance athlete, they have a very high vagal tone, so acetylcholine activity is there. Now this acetylcholine activity is superimposed by having sympathetic activity in the form of the noradrenaline. Then what is happening? Then what is called there is more decrease in the APD, that is action potential duration, and the heighten the length of the calcium transient. So there occur mismatch between a VM and a CT, and this causes development of the EAD, that is arterial early after depolarization. And this early after depolarization and with associated with the pause and pause, they may further increase decrease the action potential duration as well as calcium transient, and it will lead to the production of the repetitive rhythm in the form of the atrial fibrillation. So this is the basically the basic concept is disparity between VM and CT is very important, and this disparity is resulting in the inward sodium calcium exchanger current producing EAD. EAD is the earlier after depolarization, and if after for example, if even after further enhancement of the CAT is observed after the tachycardia post interval, and a second action potential may be initiated here. Second action potential may be initiated here. It is initiating a second action potential here, and this second the calcium transient is initiated by the first ectopic beat. The first ectopic beat, and that initiate the second ectopic beat, and so on. The first ectopic beat will initiate the second, and this can continue, and it will create into a repetitive rhythm like pattern, like in case of the atrial fibrillation. So this one has to remember. So so here again similarly, so in cases for example, if you see here, this is the atria tachycardia is present. This is left atrium, and this is the physiological marking of the SGNA. SGNA is nothing but the satellite ganglion. It denotes the sympathetic system, sympathetic activation. VNA is the vagus nerve activity. Vagus nerve activity, like it is the parasympathetic activation. So if you see here, this is the vagus nerve activation. The vagus nerve activation accompanied by sympathetic activation leads to the atrial fibrillation. So atrial fibrillation, for atrial fibrillation to occur, in addition to the vagus nerve activation, sympathetic activation has to be there. So this is important. Another one, A and B are just continuation of the graph. Another one, if you see the ventricle side, so ventricles, this is the ventricle, this is the ECG. Here you can see the onset of the ventricle fibrillation. So in ventricle fibrillation, what is important is, if you see the ventricle fibrillation around, it is approximately 40 seconds before there occur activation of the sympathetic system. So sympathetic system activation is sufficient for ventricular fibrillation. So sympathetic system is arrhythmogenic for atrial fibrillation as well as ventricle fibrillation, whereas vagus nerve is arrhythmogenic for atrial fibrillation but not for ventricular fibrillation. This is important. So because vagus nerve causes prolongation of the action potential duration and effective refractory period prolonged in ventricle, but not in the atria. But not atria, we see that there is causes shortening, and since effective refractory period is shortened, then there is always high chance of the development of the ectopic and development of the generation of the atrial fibrillation. That's why vagus nerve is arrhythmogenic in atria but anti-arrhythmogenic in ventricle. But sympathetic is pro-arrhythmogenic for both atria as well as ventricle. So that's why by knowing this basic electrophysiology, we can say that why atrial fibrillation is present in case of the endurance and mixed sports, because here the vagal tone is very, very high, and why they are mostly present during the athlete, because the athlete has a higher vagal tone and they have a high chance of taking various illicit drug and sports supplement, as well as the fibrosis may happen just in case of the Philippines cardiomyopathy. So next, let's go to the next scheme. In case of the COVID-19, COVID-19 is important because the exercise rehabilitation is an important part of the rehabilitation return to activity after post, after COVID and post-COVID syndrome. Pulmonary rehabilitation, cardiac and exercise rehabilitation has to be part. A multidisciplinary approach has to be done for, and different guidelines are there for COVID-19 rehabilitation. This is absolutely important. So what I want to focus here is there is very minute chance of sudden cardiac death in athlete. It may be because of the acute and subacute myocarditis and pericarditis, like say 5 to 25%. But one thing which one has to remember is after post-COVID or viral myocarditis, there is a very less chances there, but still there is possibility is high. And out of this possibility, 5 to 25% of sudden cardiac death in athletes may be associated myocarditis and pericarditis. And apart from that, heat exhaustion may be there, post-viral fatigue syndrome may be there if exercise is being done in case of the viral, infection. So one has to understand the certain do's and don'ts, as far as COVID-19 is concerned, as far as different viral infection is concerned. Like, for example, this is the recommendation given by Indian Society of Sports and Exercise Medicine, like we. So what are recommendations about if there is unusual and unexplained alteration in activity of the rating of the physical exertion is there. If there is a slight alteration, then it may indicate COVID-19 infection in case of the athlete. So COVID-19, even if you are asymptomatic, but if you do a mild changes or unexplained or unusual changes happening in the activity, perceived exertion to the activity, then that may be indicated of the infection also. So asymptomatic COVID-19 positive player, the player who are asymptomatic, they have to restrain for intense activity for at least 2 weeks. And no sports participation should be there for symptomatic player, but without pneumonia and myocarditis. If there is no pneumonia and myocarditis, then and for a mild symptomatic player, no sports participation should be there for at least 2 to 4 weeks. For if there is a pneumonia, then it has to be more than 4 weeks. For pericarditis, at least 3 months, and for myocarditis, 6 months. One should not participate in intense sports. So these are the interval which are required for healing of the myocardium, and this may be followed by intensive testing, including the cardiac MRI. Where the possibility of the patchy fibrosis, where the possibility of the cardiac scarring has to be done, we have to know. In case of the recovered player, if there is no symptoms for say 7 to 10 days, more than 7 to 10 days, or if it is more than 10 days of the first symptom onset, then return to play may be done with the initial say minimal exertion for up to 2 weeks, equal to or more than 2 weeks. Then minimal exertion exercise should be done, and pre-COVID activity may be gradually reached after say 4 to 5 weeks. And medical evaluation and the relevant cardiopulmonary ergometric, the exercise stress test, biochemical parameter, including all the cardiac enzyme, they are absolutely needed before a decision is done for return to play. We have published a paper regarding this for in swimming also. So now from exercise, I'm going into more into what you call the clinical aspect of exercise medicine, like in case of the obesity and overweight. In case of the obesity and overweight, by just following the FIT principle, this is the guideline which may be used. Like, for example, in case of the aerobic training, can be given like equal to more than 5 times per week. But most of the days of the week, that is 5 days a week, or resistance training 2 to 3 days per week can be given. Intensity maybe 40 to 59%, or equal to more than 60% of VO2R, that is VO2 reserve, or heart rate reserve, HRR. VO2 reserve is nothing but a VO2 max minus the VO2 consumed at resting VO2, or resting VO2 is approximately equal to 1 MET. 1 MET is what we consider as a resting, VO2, 3.5 ml per kg per minute. Then resistance training can be given around 60 to 70% of 1 RM, and it may be increased gradually. And these are the and different this thing can also be given like different component, like for example 3 minutes per day for 150 this is for time, that is time means duration. For example 150 minute per week or 30 minutes per day approximately can be given, or it can be increased to equal to more than 60 minutes per day, or 200 to 300 minutes per week can be given. In case of the resistance, 2 to 4 set of 8 to 12 repetition of exercise intensity should be that you should be able to do 8 to 12 repetition, and it should be focusing major muscle group equal to more than 6 major muscle group. And type of the exercise may be walking, cycling, swimming, etc., resistant machine, free weight, body weight. These are the type of exercise. So these are a fit principle here in the fit principle which I've described the sequence. I have kept the type of the exercise above, no problem, it doesn't matter. Type or time can be kept higher or lower, doesn't matter. For flexibility training also, it can be done 2 to 3 days per week, and it should be done tightness or slight up to the slight discomfort, not to the pain but to the slight discomfort. And holding static stretch can be held for say 10 to 30 seconds, and 2 to 4 repetition can be done. And you can do static dynamic or PNF stretching can be done. This is basically exercise for overweight and overtraining. But one thing which you have to remember is that if you want to lose weight, then approximately what we target is 0.5 to 1 kg per week is we target for weight loss. And 4 days around 500 to 1000 kilocalorie per day deficit, energy deficit can be created if you believe in a calorie in, calorie out model. But calorie in, calorie out model has been outdated, and there are different model for obesity is there. The thing is, we should aim for 3 to 10% of weight loss over 3 to 6 months. And if for increasing 5 to 10% weight loss, more aggressive management has to be done. Like time, you can always incorporate time restricted eating work, like eating window of 6 to 10 hours per day, intermittent fasting, or high carb, low fat diet, or keto diet, and different other methods of PE diet. There is a protein energy diet. All this important concept can be done. But one thing which you have to remember is this is just a 24-hour energy expenditure in kilocalorie. You see that the thermal effect of activities only 15 to 30%. So your exercise is able to modify only 15 to 30%. But resting metabolic rate, they constitute to 60 to 75% of your energy expenditure. And this is thermic effect of the meal, and which is highest for a protein meal, approximately equal to 10%. So exercise, may not contribute much to the weight loss, because energy expenditure is not contributed much by the weight. It's only 15 to 30%. But somehow, if you affect the resting metabolic rate, because they are mostly 60 to 75% of the energy expenditure is because of the RMR, resting metabolic rate. So if you somehow influence resting metabolic rate, then it will be good. Then how can it be? It can be influenced by diet. Different diet has been known to influence RMR. Exercise also, some exercise are also known to RMR, like some studies has been done on the strength training and high intensity interval training. They are known to affect increased RMR and different factors. So this one has to remember. Another one which affect the RMR is the level of the insulin. The insulin, the hormonal effect, because I am not talking about all the pharmacological therapy or a supplement, but selectively few hormones I want to focus upon. Like for example, if you see the resting energy expenditure is decreases in presence of the insulin. So this is a case of the insulin dependent diabetes mellitus, where intensive insulin therapy causes decrease in the resting energy expenditure. That means insulin is known to cause decrease in RMR or resting energy expenditure. This is one has to remember. But insulin causes more deposition of the fat here. Insulin decreases resting metabolic rate, including insulin causes gaining of the fat. See, lean body mass is very, very small, but the gain in the fat mass is very high. So that's why high level of the chronic insulin resistance or chronic level of the high insulin, which we typically see in case of the insulin resistance, is not good for the health. Another important is also again here If you see the TEE, that is the energy expenditure. This is energy expenditure, and if you classify different type of the diet, depending upon the level of the insulin. Like for example, this is the person having very high insulin level. Then in those person, if you take high carb diet, then the RMR, the effect of the RMR is very very severe. That means your TEE, that is energy expenditure, is very very low if you are having the baseline of higher insulin, and if you take high carb diet, or in that individual, low carb diet may be beneficial. Low carb diet along with adequate amount of the protein, they may have a good effect on increasing TE. But however, in case of the highly insulin sensitive person, the person who is having a lower insulin level, which are sensitive, then not much difference is there. Whether you take high carb diet or low carb diet or moderate carb diet, not much difference is seen in case of the energy expenditure. That's why the knowledge of the baseline insulin sensitivity status or insulin level is extremely important, because whatever you are taking the diet, whatever your body is reacting to that particular diet depends upon your the hormonal state. This is the carbohydrate insulin model for obesity, hormonal model for obesity. So obesity is not a problem of energy, calorie in, calorie out, because our system is not a physical closed system, but our system is a what, physiological adapting, interacting system, not one single system, but interacting different compartment, not uni compartment but multi compartment system, where hormones plays an important role on how the diet which you are taking interact, how you respond to the diet you are taking to the body. This is important. So next, going to the concept of the people who think that strength training doesn't go fat loss. So this misconception is there. It is not so. Strength training is the gold standard for increasing lean muscle mass. Everybody knows, and lean muscle mass is directly proportional to resting metabolic rate. So resting metabolic rate is dependent upon lean body mass, and strength training, by increasing lean body mass, they can increase the RMR also. But what about the fat loss? Fat loss, whether strength training or aerobic training. They see strength training, one study which they have performed, they have said that strength training will causes same percentage fat loss, fat mass, as well as visceral fat mass loss as compared to the aerobic training. So strength training not only increase your lean muscle mass, they also decrease your fat mass, and that's why it causes more improvement in your body composition. And just like what I have told you, the strength training may have more RMR, and since RMR is mostly 24-hour the energy expenditure by increasing the lean body mass, so strength training has an important role in weight loss. Another important point is, if you do high intensity training and strength training, then just after the exercise, then there is something known as EPOC, or oxygen death. Oxygen death or EPOC is excess post exercise oxygen consumption. So where you are consuming more oxygen after the exercise, this EPOC may be higher. This is also known as after burn effect. This EPOC may be higher in case of the strength training. So in case of the high intensity interval training, so in during the exercise itself, you may not be able to burn more of the fat, but after the exercise, because of this EPOC, more oxygen consumption, you are burning more fat after the exercise. It is possible after high intensity interval training as well as strength training. So this is the concept of after burn effect. So going ahead with the diet and the carbohydrate insulin model, which is one of the model which was given by different speaker, like this is the slide from Dr. David Ludwig. And the important what he has says that the carbohydrate diet or all the highly processed food, they causes increased insulin secretion, and insulin is an anabolic hormone. They prevent the fat utilization of the fat, and therefore fat storage is promoted by the insulin. And different stress like sleep deprivation, stress, physical inactivity, and all this will affect the fat storage, and they may affect the insulin resistance also. If you take different protein, micronutrient, prebiotic, these all affect the fat storage. Your endocrine problem disruption also, they will affect the fat storage. And And since fat storage is there, so there may decrease circulating fuel like glucose and lipids may be decreased, and because of this decrease, the energy intake will have to be increased, and that's why hunger is being caused. The hunger, the body, because not fuel is the fuel has been packed into storage, and you are not able to access that fuel because of high level of the insulin and other problem. Your body is not able to utilize the fuel, and hence there will be more hunger, and hence more intake is there. So energy expenditure also, resting energy expenditure also, insulin causes decrease in resting expenditure. Fatigue may be there, muscle efficiency may be reduced. So this is basically the carbohydrate insulin model. And you see there it is a hallmark of the insulin resistance, and it may be because of the high insulinemia itself. High level of the insulin itself causes insulin resistance, or it may be because of the cortisol, it may be because of the epinephrine, it may be because of the stress, it may be because of the sleep deprivation. This may causes insulin resistance, or inflammation, oxidative stress, it may causes inflammation, insulin resistance in adipocytes, liver, muscle, and pancreas. And ceramides are important molecule. They are the sphingolipids, and these ceramides are basically generated with in case of the insulin resistance, in case of the inflammatory and oxidative stress. They are also known as lipotoxicity, where intracellular accumulation. If the fat is accumulated in the adipocyte, which are designed to accumulate fat, no problem. But if the fat is accumulated, ectopic fat accumulation, otherwise, like in muscles, like in liver, like in pancreas, like in like in other cells, then problem will arise. So that's why. And if that lipid accumulation is ceramide in the form of the sphingolipid, then it will cause insulin resistance again. So ceramide monitoring is one of the most effective for cardiometabolic health and different health, and it may be more important than the total cholesterol. This one has to remember. So insulin, since hyperinsulinemia causes insulin resistance, we have to know which major diet component causes increase in insulin. It is the carbohydrate as compared to the fat. The fat causes minimum rise in blood insulin level as compared to the carbohydrate, and that's why in those patients who are having high or already high level of the carbohydrate, the diet is affects the diet. The response to diet is significant. In those individuals. Like for example, if you keep on snacking in different interval, then your rise in insulin will be very, very high, and it may ultimately lead to the more storage of the fat and more hunger and satiety. Less satiety will be there. So this one has to understand. Apart from the insulin, you have to know the glucagon also, because what you want is you want a relatively low insulin and relatively higher glucagon. There is I by G ratio, relatively lower I by G ratio. Why this is required? This is required for utilization of the fat, yani catabolic process. You require this low I by G ratio for catabolic process, so that you utilize the stored fat in your body for thinning purpose. You require the glucagon to be relatively high, and the decreased insulin and the relatively high glucagon is also necessary for beta oxidation of the fatty acid, and hence subsequently for nutritional ketosis or ketone generation. So you require this ratio. And the carbohydrate, carbohydrate causes increase in insulin, and these are the important. And the fat also, and decrease in glucagon. Fat doesn't affect much of the insulin, but increase glucagon. But in protein intake is also important. What about the protein? The protein intake depends upon the status of that particular individual. If the particular individual is highly insulin sensitive, or if the particular insulin is taken, a particular subject is taken in low carb high fat diet, healthy low carb high fat diet, then by addition of the protein will not cause much of the rise in the insulin, but it will be relatively more rise in glucagon. So I by G ratio will be decreased. But however, this is not the case in those individuals who are insulin resistant, who are hyperglycemia, who are already high glucose level is already present in their blood, or those who are taking high carb and the low fat diet, high carb diet, in those conditions, if you take protein, then what will happen? Excessive in disproportionate rise in insulin is happen as compared to the glucagon. The glucagon rise is not much, but insulin rise will be there. So I by ratio will be high there. So that's why if you do, in case of the fasting, if you do add protein, then the fast I by G ratio of the fasting is approximately 0.8. So if you add protein, then in case of the fasting, this effect happens where because fasting basically improve your insulin sensitivity. So the glucagon will be higher as compared to insulin. So I by G ratio will be lower. That is 0.5. If you are taking low carb diet, then your I by G ratio is approximately 1.3%. And if you take protein in the low carb diet, then I by G ratio doesn't change much, only 6% change, approximately it remains 1.3%. But if you take protein in hyperglycemic or insulin resistant state, then I by G ratio will be very, very high. In fact, it may rise from 4 I by standard high carb low fat diet. I by G ratio is 4. So addition of the protein may rise it into 70. That is 20 times higher. So that's why the protein intake may be problem, may causes more rise in insulin in those individuals who are already on high carb diet and hyperglycemia, or which are on what you call insulin resistance state. So that is the important point which you have to remember as far as protein intake is concerned. But protein intake is highly encourageable for those individuals who are highly insulin sensitive in fasting also, and ideal for the nutritional ketosis also. Because one thing you have to remember, insulin causes decrease in resting metabolic rate. Insulin causes brown fat. Brown fat is the one which causes uncoupling, where more burning, excess production of the heat is there, but not much production of the ATP. Uncoupling is there. So brown fat, basically what they are doing is, brown fat is there for generation of the heat as compared to ATP. And this brown fat, the more the brown fat is present, the more your resting metabolic rate will be there. So insulin basically causes this brown fat turn into white fat. White fat is the one where a storage form of the fat, where not much mitochondria is there, where uncoupling is not there. Uncoupling, oxidative phosphorylation is not there. But low insulin means basically means ultimately means nutritional ketosis, nutritional ketone, that like beta hydroxybutyrate, acetone, and acetoacetate, and the most important is the beta hydroxybutyrate. So if you add ketone body, the ketone body has been known to increase brownization of the white adipose tissue. White adipose tissue may become brown, brown adipose tissue transition is happening, and because of that our resting metabolic rate may increase, and hence it is very much useful for weight loss and for maintaining healthy weight loss. But everything, it has to be given in context, and it has to be individualized. One doesn't fit for all. This you have to remember. Another one which I want to focus is, you don't have to be if you decrease taking hypocaloric diet, then what is happening? If you do hypocaloric diet, then hunger will be there, and though self-torturing will be there. So you have to understand what causes hunger, what causes craving. Like for example, this was the graph I have taken from Dr. Stan Igberg. Like in case of the high food, comfort food is there. Comfort food means high processed food. Then this food will causes high blood glucose and all that stuff. This will raises insulin. This insulin will promote storage of the fat, and insulin will decrease the blood flow. This is known as a reactive hypoglycemia, and this, because of the reactive hypoglycemia, the availability of the nutrients will be less relatively, and this is and this will be accompanied with a more release of the cortisol and others, and stress is also release cortisol, and this may affect the craving. So thereby so this cycle can go on to reactive hypoglycemia, and also decrease availability of the free fatty acid, and increase availability increase stress, cortisol and all that will causes more craving. The more you eat high processed diet, the more craving will be there. Like for example, if you see the concept of the reactive hypoglycemia, see three diets are given: high glycemic, medium glycemic, low glycemic load diet. And in case of the high glycemic diet, initially there was very high glucose was there, blood glucose was there, but subsequently blood glucose fall even lower, as compared to other diet. And since there is statistically significant fall in blood glucose by taking high glycemic load or high glycemic diet, and high glycemic diet is associated with more hunger and less satiety, and this will accompany with more food intake. If you see the food intake is always more for high glycemic index or high glycemic load diet. And that's why you have to understand the principle of the craving. So if you want to reduce the craving, then you have to take something, some good fat or something, not high processed carb, especially high carb, high glycemic diet. You have to avoid such diet if you want to increase your satiety. Another point, if you want to increase your satiety is based upon the principle of the energy, energy versus protein. This was being given by Dr. Ted Neyman. Protein and energy in the form of non-fiber carb plus fat. He has basically designed a graph where he plotted different food based upon PE ratio, that is protein and energy, and this is the PE ratio is approximately 1 for hunter-gatherer population. Hunter-gatherer population where our ancestor and the different population of hunter-gatherer nowadays, which we are seeing, where obesity and metabolic diabetes, hypertension, and all the cardiometabolic illness are not so common there. So their diet is highly consistent of the protein and less of the energy. And this is the what standard diet. Standard diet is 0.2. That is we are consuming more of the carb, more of the energy, but less of the protein. Why protein intake is so much important? Because protein intake is important because your body tends to take more carbohydrate and fat if that food contains less protein. So this is the concept here. Suppose if you see this graph, this is the x-axis, this is the percentage of the protein in fat, this is the percentage of the food ingested. If you see the diet which is composed of the higher protein percentage, then your consumption, this is your energy consumption. So your energy consumption in the form of the fat and carbohydrate and fat is decreases. That means the protein, if you have high protein diet, then you will be reaching satiety more. You will be more satiety. Less craving will be there and less consumption of carbohydrate and fat will be there. But if your food contains less of the protein, then you have to compensatory increase consumption of the carbohydrate and the fat. That is, increased energy consumption has to be there in order to achieve that the protein which is needed by the body. So this concept is important. So if a particular food is lack of essential amino acid and protein, lack of the protein, then you will keep on eating. You basically end up into over consumption of carbohydrate and fat. But if you have a high quality of the good nutrient dense food, then what will happen is you will consume less and your satiety will be more. So the protein prioritization is absolutely important, and which you have to understand also. Another point which one basically asks is regarding the intermittent fasting. Intermittent fasting is important for as far as insulin is concerned, because intermittent fasting, if you do intermittent fasting for a longer time as compared to the low caloric diet, if you do intermittent fasting, then intermittent fasting will progressively causes less insulin level. That means your insulin sensitivity will be improved. And one question where people ask is, since you are doing intermittent fasting, if there is increase in resting metabolic rate, then if there is decrease in resting metabolic rate, then there will not be any benefit for intermittent fasting, because energy expenditure will be low. You are taking less calorie, but still you are burning less calorie, then everything will be equilibrium. But this is not so, especially in as compared to low caloric diet, because low caloric diet has been shown to decrease resting metabolic rate after a particular time. So if you are taking less calorie but you are not burning also, so a kind of equilibrium is achieved. But in case of the intermittent fasting, it may not be the case, and resting metabolic rate in the form of the RER is relatively maintained over say 4 days of the fasting, and weight is also sheer a decrease. In spite of the decrease in the weight, the resting metabolic rate it may a little bit increase also. And say similarly VO2 oxygen consumption also relatively increase. So resting metabolic rate may in fact little bit it remains the same, or it may little bit increase. This is the importance of the intermittent fasting. Another point which I want to focus on intermittent fasting is whether intermittent fasting affect your craving and hunger. Ghrelin is a hunger hormone, and if you see the craving, if you go on increasing the fasting duration, you can see that the level of ghrelin drops. If you keep on decreasing, if you keep on decreasing, that means with intermittent fasting, with increasing phase of the intermittent fasting, with increasing duration of the intermittent fasting, your hunger actually decreases. Your body adapted, your ghrelin level will decrease. So this is the important basic importance of intermittent fasting. So what you have to understand is you have to avoid certain diet which are comfort food, like high processed food, high processed, especially a high carb diet, processed carb, and all the processed fat and processed food. And you have to do intermittent fasting, and you have to prioritize your protein by focusing on the ratio where your diet is basically lying, in which zone it is lying, and depending upon this thing, you can basically go ahead with management of the obesity, hypertension, obesity, and cardiometabolic issue like insulin resistance, and insulin associated problem, like it may be hypertension, it may be diabetes, it may be type 2 diabetes, and all PCOS, all this cancer, all this condition which you can easily manage by using diet and exercise as a medicine. Here exercise is also absolutely important, because exercise is known to causes increased insulin sensitivity. You must be knowing that in the secondary messenger pathway for insulin, for GLUT4 translocation, AMPK kinase is one of the mechanism for increased translocation of GLUT4 receptor to the membrane, and exercise is the one factor which causes translocation of the GLUT4 receptor independent of the insulin. That's why exercise causes increased glucose take up by the muscle independent of the insulin, and hence insulin sensitivity is important, and hence exercise is an important apart from the diet, important physiological intervention which is absolutely required for insulin resistance, as well as for a treatment of type 2 diabetes, pre-diabetes, and obesity, and all that stuff. So I am coming to the end of my talk. So my the take-home message is the physical activity, exercise, and positive lifestyle, they would lead to positive physiological adaptation, and this will ultimately lead to performance, fitness, and health. And you have to consider different functional medicine point of view, as well as from lifestyle medical point of view, a different physiological intervention like exercise, exercise and diet. Like for example, you have to control your carbohydrate intake. This is especially in case for those who are carbohydrate intolerant. Those person who are having carbohydrate intolerant. In those person who are having insulin resistance, they may take less, maybe less than 100 gram per day or 50 gram per day, depending. I am not talking about the players or the carb burner players. I'm not talking about them. And for you have to prioritize your protein. You may take around 1 to 2 gram per kg body weight per day, especially for elderly, where requirement of the protein increases. For athlete also, there is more requirement of the protein, 1.2 to 1.7 gram per kg body weight, depending upon which type of the exercise you are following. So protein intake is absolutely important, high quality protein, and high quality fat intake is absolutely important. You have to avoid all the trans fat and all the polyunsaturated fatty acid, especially omega 6 polyunsaturated fatty acid you have to avoid. You may take omega 3 like fish oil. Omega 3 polyunsaturated fatty acid is good, and some amount of the saturated fat also, no problem, depending upon the metabolic state you are. So healthy saturated fat, healthy monounsaturated fat, healthy polyunsaturated fatty acid in the form of the omega 3 fatty acid, not omega 6 you have to avoid. And you have to do healthy intermittent fasting. You have to avoid processed food, prefer whole natural food, avoid seed oil, all the seed oil if it is possible, you avoid it. And you have to avoid high omega 6 PUFA, polyunsaturated fatty acid. You have to do regular physical activity, exercise, and limit being sedentary. The bad effect of the sedentary is not absence of exercise. They are both different. Sedentary physiology is different from exercise physiology. You have to understand. So you have to decrease the amount of the sedentary. If you are doing exercise but still you have lots of sedentary activity, then that adverse effect will still be there. So they are independent of each other. You have to decrease the sedentary activity, you have to increase the physical activity level. You have to prioritize sleep and recovery. You have to limit the stress, increase coping and stress resilience and de-addiction, and just enjoy the life as it is. So these are the take-home messages which I want to say. And the most important point is you have to individualize everything. Whatever I have talked is the general principle. You cannot just apply as such in different this thing. Like for example, less than 50 gram per day and all that stuff, low carb diet. So you have to know when to apply, how to apply, and where to apply. So that's why your knowledge of physiology comes. So a good background knowledge of physiology is absolutely important if you want to practice functional medicine, if you want to practice lifestyle medicine, and if you want to practice sports and exercise medicine. Thank you very much.